Okay, I'm now going to continue discussing. We are now in the part of the chapter on chronic diffuse interstitial or restrictive lung diseases. So this is a table directly lifted from your book, which actually categorizes the different interstitial lung diseases that we will cover for the next hour. So let us try to go through it one by one. When you say in interstitial or restrictive lung disease, they occur in two general conditions. One is chronic interstitial and infiltrative diseases such as pneumoconiosis and interstitial fibrosis. And the second would be chest wall disorders. For example, you have neuromuscular diseases such as polio, obesity, pleural diseases, or kyphoscoliosis, for example. The classic functional abnormalities when we talk about diffuse interstitial restrictive diseases would be as follows. You have a reduction in diffusion capacity, lung volume, and lung compliance. When you do chest x-ray, it will usually give you bilateral lesions, which takes the form of small nodules, irregular lines, or ground glass shadows, which actually all corresponds to interstitial fibrosis. So the gross would be characteristically giving you scarring and gross destruction of the lung. This is what we call as end-stage lung or honeycomb lung. So these are examples of radiographs. As I have mentioned, characteristically speaking, the chest x-ray of your patient would reveal nodules or that may be bilateral. It may take the form of irregular lines or ground glass shadows, which again, as I have said, corresponds to fibrosis. So when we're talking of interstitial diseases, the common term that you will encounter would be the word fibrosis. For example, the first one is what we call as IPF or UIP. This is characteristically has the histologic pattern of which is what we call as usual interstitial pneumonia, which can be diagnosed clinically and of course on the appearance of radiographs that I have shown you a while ago. The UIP pattern can also be seen in other diseases, like for example, connective tissue diseases, chronic hypersensitivity pneumonia, and even asbestosis. So the cause of idiopathic pulmonary fibrosis remains unknown. It appears that the fibrosis arises from a genetically predisposed individual who are prone to aberrant repair of recurrent alveolar epithelial cell injury, which is caused by environmental exposure. The implicated factors can be environmental, can also be genetic, and sometimes even age. So the appearance of the lung characteristically would be cobblestone, and usually it will give you a firm, rubbery consistency. So the hallmark is what we refer to as patchy interstitial fibrosis. It may vary in intensity, and the earliest lesion usually is composed of fibroblastic proliferation. This is what we call as fibroblastic foci. It then becomes more collagenous and less cellular. So usually the dense fibrosis, as you can see here, will cause destruction of alveolar architecture and even lead to the formation of cystic spaces, which is lined by hyperplastic type 2 pneumocytes or bronchular epithelium. So the usual patients would be somewhere around 50 to 75 years of age. They are characteristically exhibiting hypoxemia, cyanosis, and clubbing, may occur later in the course. The progression in an individual patient is unpredictable. Usually, there is gradual deterioration in the pulmonary status of the patient in spite of medical treatment. The next category is what we call as NSIP, or non-specific interstitial pneumonia. The concept of NSIP emerged when it was realized that there is a group of patients with diffuse interstitial lung disease whose lung biopsy lack the diagnostic features of any of the other well-characterized interstitial disease. Despite its non-specific name, this entity is important to recognize, since patients have a much better prognosis than those with UIP, or usual interstitial pneumonia. Non-specific interstitial pneumonia may be idiopathic or associated with a connective tissue disease. When you look at it histologically, it is actually divided into two patterns. You have the cellular and the fibrosing pattern. The cellular pattern consists of mild to moderate chronic inflammation containing lymphocytes and few plasma cells in a uniform or patchy distribution. On the other hand, the fibrosing pattern consists of diffuse or patchy interstitial fibrotic lesions of roughly the same stage of development. Fibroblastic foci, honeycombing, hyaline membranes, and granulomas are often absent. So the patient will usually again present with dyspnea and cough of several months duration. When you say cryptogenic organizing pneumonia, COP, it is synonymous with the popular term bronchiolitis obliterans organizing pneumonia. Why is it called as such? Because as you can see from the illustration, it is called BOOP, or bronchiolitis obliterans organizing pneumonia, because it is characterized by polypoid plugs of loose organizing connective tissue, which we actually call as Mason bodies, within alveolar ducts, alveoli, and often bronchioles. The connective tissue is usually all of the same age, and the underlying lung architecture is normal. It is important to recognize that organizing pneumonia with intraalveolar fibrosis is most often seen in response to infection or inflammatory injury to the lungs. Sometimes it occurs on a background of collagen vascular diseases. Most autoimmune diseases, also referred to as connective tissue diseases, like for example, most notable would be as enumerated, SLE, arthritis, rheumatoid arthritis, scleroderma. This can involve the lung at some point in their course of illness. The pulmonary involvement in the lungs for this patient can take different histologic pattern. It can be in the form of NSIP. Again, what is NSIP? Non-specific interstitial pneumonia, UIP, or usual interstitial pneumonia, vascular stenosis, organizing pneumonia, or BOOP. What is again BOOP? Bronchiolitis obliterans organizing pneumonia. So we go now to the next category, which is pneumoconiosis. So when you're talking of pneumoconiosis, we are talking of particles that are inhaled, and the most dangerous of which are those that range from 1 to 5 micrometer in diameter. Why are we afraid of that? Because it tends to reach the terminal small airways and air sacs and settle in their linings. So generally speaking, the smaller the particle, the more likely it is to appear in pulmonary fluid and reach toxic levels rapidly, depending on the solubility of the agent. The larger particles will resist dissolution and may persist for the lung parenchyma, in the lung parenchyma for years. So they can cause eventually tissue injury. Now, one of the things thoroughly tackled in the book would be your co-worker's pneumoconiosis. So pneumoconiosis, generally speaking, is non-neoplastic lung reaction to inhalation of mineral dust encountered usually in the workplace. So one of the most common, like what I am trying to show you right now, is coal. Coal workers' pneumoconiosis is a lung disease which is caused by inhalation of coal particles and other admixed forms of dust. Usually, this is very common among coal miners. And as you can see, there is a spectrum of lung findings. It may be asymptomatic, it may be simple, or it may be actually complicated. So they are usually coal miners, and these are examples of images showing you the nature of work, what they are getting, and of course, the lung that is affected with CWP. So this is what we call as coal or carbon or anthracosis. Anthracosis is the most innocuous coal-induced pulmonary lesion, and it is, again, as I have mentioned, often seen in coal miners. The inhaled carbon pigment is engulfed by your macrophages, alveolar or interstitial macrophages, which accumulates in connective tissue along the lymphatics and eventually may blacken the lung. As you can see, it can range from simple to complicated. When you say simple, coal workers' pneumoconiosis, what we mean by that is often it is characterized by coal macules, the diameter of which is around 1 to 2 millimeter. When it gets to be larger, that is then what we call as complicated coal worker pneumoconiosis. So the problem with complicated coal workers pneumoconiosis is usually there is progressive massive fibrosis. So again, as I have mentioned, usually there is progressive massive fibrosis. Complicated coal workers pneumoconiosis occurs usually on a background of simple disease and generally requires many years to develop. So the blackened scars started as a coal macule, eventually going into as coal nodule, may coalesce and form larger blackened areas, which may even reach around 10 centimeter in diameter. In the former image, as you can see, the lungs is basically black. So that's an example of complicated coal workers pneumoconiosis. So complicated coal worker pneumoconiosis is usually intensely black scars is expected. The microscopic feature would give you dense collagen and of course pigment deposition. And the clinical course is usually benign, but in less than 10%, it may go into progressive massive fibrosis. So this is just again another illustration showing you the expected sequelae of the disease should it progress to complicated case. So that's the first, which is coal. Second would be silicosis. Silicosis is a lung disease caused by inhalation of crystalline silicon dioxide, or otherwise known as, or commonly known as silica. It is usually presenting after decades of exposure. It is a slowly progressing nodular fibrosing pneumoconiosis. It is regarded as the most prevalent chronic occupational disease in the world. So, what happens in silicosis? In silicosis, it is characterized grossly by discrete pale to blackened nodules, often seen in the hilar nodes, usually then in the upper lobes of the lungs. As the disease progresses, these nodules tend to coalesce into hard collagenous scars. So as you can see here, the nodules are very much evident. Fibrotic lesions may occur eventually in the hilar lymph nodes and in the pleura. Sometimes calcification may also be present. So let's take a look at it closer. So this is an example of the whorled collagen fibers, which is the hallmark of the disease. Examination of the nodules by polarized microscopy would also reveal birefringent silicate particles. So this is an example of image showing you the weakly birefringent silica particles that is best confirmed utilizing, again, fluorescent microscopy. So as I have said, it is a chronic progressive disease. The radiographs, when taken, will typically show the fine nodularity in the upper zone of the lungs, because as I have mentioned, it is often seen in the hilar area. So it is usually giving rise to impaired pulmonary function test. Bear in mind that there is an increased risk for the development of lung cancer among this patient. The onset of silicosis may be slow and insidious. Basically, around 10 to 30 years after exposure is the usual timeline. It may be accelerated. This is within 10 years of exposure. Or for some, it may also be rapid, occurring in weeks or months after intense exposure of fine dust that is high in silica. So again, the risk for lung cancer, double for patients with silicosis. Next would be asbestos. Asbestos is a pro-inflammatory crystalline hydrated silicates, which is also associated with pulmonary fibrosis, carcinoma, mesothelioma, and other cancers. The other occupational exposure is also related to a variety of diseases, as you can see enumerated in this particular slide. They are basically looking like this. So occupational hazard again. Asbestos takes two forms. The word S there is what I would recommend for you to remember, that 90% of cases of asbestos is what we call as serpentine. Serpentine. And the other one is the A there should remind you that the other type is what we call as amphibole. So there are two types, amphibole and serpentine. Between the two, amphibole is regarded as more pathogenic, particularly with respect to induction of mesothelioma. Mesothelioma is a malignant tumor which is derived from the lining layer of the pleural surfaces. But bear in mind that both amphiboles and serpentine are fibrogenic, and increasing doses are associated with a higher incidence of asbestos-related diseases. So how do we diagnose it? When you look at the lung parenchyma, fibrosis is expected, but you may also see what we call as asbestos bodies. Asbestos bodies looks like this. Asbestos bodies are usually appearing as rocket-shaped structures. As you can see here, they are usually with elongated and then somewhat an ovoid structure right at the tip. They tend to contain iron, so that this is an example of an iron stain. Asbestos bodies are usually, as I have said, fusiform or beaded rods. They usually contain asbestos fiber and they are coated with iron-containing proteinaceous material. So this is staining blue because it is particularly an iron stain. So the usual is it begins in the lower lobe and subpleurally. It is usually causing pulmonary hypertension and cor pulmonale. The most common manifestation that you would see would be pleural plaques. Pleural plaques appear like this. So pleural plaques are the most common manifestation of asbestos exposure. They are well-circumscribed plaques of dense collagen. They develop most frequently on the anterior and posterolateral aspects of the parietal pleura and over the dome of the diaphragm. So again, on your right is an example of asbestos body. So do not forget, again, they have increased risk of developing lung carcinoma. This time it is 5 times, and mesothelioma around 1,000 times. So the clinical findings rarely appear fewer than 10 years after first exposure, and more often after 20 to 30 years. Dyspnea is usually the first manifestation. It is often provoked by exertion, but later it will be even at rest. Cough is expected to be associated with production of sputum. Chest X-ray would give you irregular linear densities, particularly, as I have mentioned, in both lower lobes. With advancement of the pneumoconiosis, a honeycomb pattern eventually developed. So sometimes the drugs we give to our patient can actually cause complications like pulmonary fibrosis. This is an example of a rundown of the different drugs that may have or may lead to pulmonary fibrosis, hypersensitivity pneumonitis, or basically bronchospasm. Now, let us take a look at other possible therapies. Radiation pneumonitis is also a well-known complication. It is often given to thoracic tumors like esophagus, breast, mediastinal, and of course the lungs. It is most often involving the lung within the radiation portion. Acute radiation pneumonitis occurs 1 to 6 months after irradiation. The patients will usually present with fever, dyspnea, out of proportion to the volume of lung irradiated. It can also be chronic radiation pneumonitis. And among this patient, the most predominant manifestation that you would see would be pulmonary fibrosis. Okay, let us go to the next category, which is granulomatous diseases. Sarcoidosis is a systemic granulomatous disease. It is a systemic granulomatous disease of unknown cause. It may involve different tissues and organs. Usually, it involves the bilateral hilar nodes, and it is usually occurring in 90% of the cases. So when you do the physical exam, do not forget then to take chest X-ray, focus on the hilar nodes. Another thing is the eye. The eye lesions and skin lesions are the ones that are next in frequency. So check the eye, the skin, and of course, do your X-ray for your hilar nodes. Sarcoidosis usually occurs in adults younger than 40 years of age, but it can affect any age group, the prevalence of which is higher in women, but it may vary widely in different countries and population. So if you take a biopsy, so let's say we take a biopsy of this skin lesion, we are expecting to see non-cacheating granulomas. What is the pathogenesis behind that? In the etiology of sarcoidosis, the etiology remains unknown, but there are several evidences that suggest that it is secondary to disordered immune regulation in genetically predisposed individuals. There are several immunologic abnormalities in the sarcoid granuloma that suggest that it is a cell-mediated immune response to an unidentified antigen. For example, the ones I'm showing you right now are examples of abnormalities in the intraalveolar and interstitial accumulation, the increased level of cytokines, which then points that this is somewhat related to a cell-mediated immune response. So, additionally, there are systemic immunologic abnormalities in individuals with sarcoidosis. They often present with allergy to common skin tests, such as Candida or PPD, polyclonal hypergammaglobulinemia, which is somewhat again pointing out to a helper T cell dysregulation. It sometimes runs in the family, and this is related to HLA genotypes. So do not forget, the classic appearance would be non-cacheating granulomas. In addition to non-cacheating granulomas, so on your left is an example of non-cacheating granuloma. Basically, every organ in the body can be involved with and have this lesion of non-cacheating granuloma. But regardless of the tissue, they will look the same under the microscope. They will be non-necrotizing granulomas. Granulomas are expected to be composed of epithelioid macrophages. They are often with giant cells. The central necrosis is unusual. In addition to granulomas, you may also see laminated calcium concretions. And this is what we call as Schaumann bodies. You may also see asteroid inclusion bodies. And these are another structures which is also again commonly seen in patients with sarcoidosis. So let's try to wrap that up. That's granulomas, Schaumann bodies, and stellate asteroid inclusion bodies. So the lungs may have nodules. As I have said, microscopically, you look for granulomas. You can have an assay of the CD4, CD8 count, which will actually give you an idea that it is cell-mediated immunity somewhat. And as I have said, the involvement can be in multiple organs, but the lesion would appear the same. So the granulomas are expected to be present in any of the organs enumerated. So the course of granuloma is basically unpredictable. It may be discovered unexpectedly on routine chest films as bilateral hilar adenopathy, or may present with peripheral lymphadenopathy, cutaneous lesions, eye involvement, splenomegaly, or hepatomegaly. But in a great majority of cases, individuals will seek your attention as doctors because of respiratory abnormalities. Often they would be coming to you with shortness of breath, cough, chest pain, and even hemoptysis, accompanied by constitutional signs and symptoms. Okay, let's move on. So this is a table showing you this time interstitial lung disease still, but these are the next diseases that we are supposed to tackle. We're going to cover hypersensitivity pneumonitis, Goodpasture syndrome, idiopathic pulmonary hemosiderosis, eosinophilic granuloma, and idiopathic pulmonary fibrosis. So let's try to tackle the first one. Hypersensitivity pneumonitis is called as such because it is immune-mediated, it is predominantly interstitial, it is caused by prolonged exposure to allergens, and the affected individual may have abnormal sensitivity or heightened reactivity to the antigen, which leads to pathologic changes which primarily involves the alveolar wall. That's why it is otherwise known as extrinsic alveolar or extrinsic allergic alveolitis. So there are different types. So it depends on, the name is actually dependent on the type of exposure. The exposure I'm referring here is usually occupational. So it may be farmer, pigeon, or humidifier or air conditioner lungs. When you do an assay of the fluid again, say the pleural fluid, it again would suggest that hypersensitivity pneumonitis is an immunologically mediated disease. The BAL stands for bronchoalveolar lavage. The BAL from the acute phase will show increased level of chemokines. It will also consistently demonstrate increased number of CD4 and CD8 lymphocytes. Most patients will have specific antibodies against the causative antigen in their serum. Complement and immunoglobulins have been demonstrated as well. Non-cacheating granulomas are also evident. So this is an example, again, of hypersensitivity pneumonitis. Particularly, we're talking of pigeon breeder's lung, otherwise known as bird fan shares disease. It is provoked by proteins from serum, excreta, or feathers of birds. So, hypersensitivity pneumonitis is often centered in the bronchioles. They include interstitial pneumonitis, granulomas, as I have said, and fibrosis. The acute attack may be heralded by fever, as I have explained, dyspnea, cough, and leukocytosis. You need to do pulmonary function test, which will then give you an idea that your patient is having progressive respiratory failure. The chest X-ray is expected to have micronodular interstitial infiltrates. The symptoms will usually appear 4 to 6 hours after exposure and may last for 12 hours to several days. Now, the next on the list is what we call as pulmonary eosinophilia. So the term to remember here is eosinophils, of course, and how much of which is present, because that will then differentiate the different types of pulmonary eosinophilia. Take a look at this slide. So the BAL here is more than 25% eosinophils. The second category would be acute eosinophilic pneumonia with respiratory failure. And the third would be secondary eosinophilia, which is usually associated with parasitic, fungal, or bacterial infection. Although relatively rare, there are several clinical and pathologic entities that are characterized by infiltration of eosinophils. This is recruited in part by elevated alveolar level of eosinophil attractants. Particularly, we are talking of interleukin-5. So when a patient is having pulmonary eosinophilia, usually they have focal areas of cellular consolidation of the lung substances, which is usually distributed in the periphery of the lung field. They may also have heavy aggregates of lymphocytes admixed with the eosinophils that I have pointed out a while ago. So when you take a look at the X-ray of these patients, so we have the biopsy. Of course, before you do the biopsy, ideally you will often request for a chest X-ray. And as you can see, the nodularities are evident on the image I am showing you right now. So again, pulmonary eosinophilia is expected. You have to perform a bronchoalveolar lavage count, which will actually give you an idea that the eosinophils are expected to be more than 25%, and this will be reported by the medical technologist or the pathologist who actually examine the fluid. So, smoking-related interstitial diseases, on the other hand, are grouped into obstructive and restrictive. Obstructive, we've talked about that. If you will recall, emphysema, chronic bronchitis, I have already discussed that in the first portion of the lecture. Restrictive or interstitial diseases. So when we say restrictive, smoking related, we actually have two patterns. The first one is what I'm showing you right now, and that's what we call as desquamative interstitial pneumonia. The most striking feature of which would be large number of macrophages in the air spaces. The macrophages were originally thought to be desquamated pneumocytes. That's why it's otherwise known as DIP. This is how it looks like histologically. So the most striking finding is the accumulation of a large number of macrophage with abundant cytoplasm, otherwise known as smoker's macrophages. The alveolar septa is expected to be thickened. Inflammatory infiltrates are often in the form of lymphocytes, plasma cells, and occasionally eosinophils. Patients with DIP usually have an excellent response to steroid therapy and cessation of smoking, but occasional patients may also progress to interstitial fibrosis. So again, that's DIP. Now, the other one is what we call as respiratory bronchiolitis associated interstitial lung disease. So this is the second, RBAILD. Again, that stands for respiratory bronchiolitis associated interstitial lung disease. This is marked by, again, interstitial inflammation, chronic inflammation, and peribronchial fibrosis. So this is an example of a bronchiole, and as you can see, fibrosis is evident surrounding it, hence the term peribronchial fibrosis. Chronic inflammation is expected. Again, it is characterized by, as you can see here, there are a lot of brown pigments, pigmented intraluminal macrophages, usually evident in the bronchioles. The changes may be patchy or it may be bronchiolocentric distribution as what I am showing you right now. Okay, let us go to the next category, which is pulmonary alveolar proteinosis. It is a rare disease. It is caused by defect in granulocyte macrophage colony stimulating factor or pulmonary macrophage dysfunction, which results in accumulation of surfactant in the intraalveolar and bronchial spaces. To diagnose the disease, of course, you again have to do a chest X-ray, and it can actually be an assay too of the expected circulating neutralizing antibodies. Autoimmune PAP is caused by circulating neutralizing antibodies specific for GM-CSF. It occurs primarily in adults, around 90% of all cases of PAP, and it lacks any familial predisposition. So, assay of this antibody can also be done. Loss of GM-CSF signaling blocks the terminal differentiation of alveolar macrophages, which impairs their ability to catabolize the surfactant. So as a result, you are expecting it to accumulate within the alveoli as pinkish proteinaceous material. Now, PAP can also be secondary. So with secondary PAP, these are the usual common causes. It is speculated that these diseases somewhat impair macrophage maturation or function, which again leads to inadequate clearance of surfactant from the alveolar spaces. It may also be hereditary. With hereditary, though this is extremely rare, it often occurs in neonates and it is caused by mutation that disrupt genes involving GM-CSF signaling pathway. Particularly, we're talking of GM-CSF and GM-CSF receptor gene mutation. So this is an example of a description of the morphology that I am trying to explain, but I think I would like to show you the image and explain again at the same time. As I have said, it is characterized by homogeneous granular precipitate within the alveoli. So as you can see here, that's the alveoli, pinkish, containing the expected deposit. There is, so as it is depositing in your alveoli, you're expecting that the lungs is, of course, heavier than normal. The alveolar precipitate is characteristically periodic acid shift positive. It contains cholesterol clefts and surfactant proteins. Ultrastructurally, the surfactant lamellae in type 2 pneumocytes are also normal. So again, what do you expect? Cough, usually with chunks of sputum appearing as gelatinous material. They may have symptoms for years. These patients are at risk, of course, for developing secondary infection. Okay. So again, I'm giving you a 5-minute break before I proceed to the next topic, which is now diseases of vascular origin.